Dr. Das, who will present his Acuity Pyramid presentation. Over to you, Debs.
Grant, can everyone see that? Nick, can you see my screen?
Yes, we can.
Perfect. Grant, thanks everyone. Thank you very much. I'll just introduce myself again. I'm Dr. Das. I'm the cardiology consultant at Barts. I'm also the founder and creator of the remote monitoring solution that is being used across a number of these pathways. Essentially, I've been trying to deliver remote care for now nearly 8 years, and as you've seen over the last 3 years, then there's been a real big shift towards post-COVID remote care, but really focusing on the term virtual ward. That's really a kind of a terminology that's come in over the last 3 years. And often I've found there's been kind of an interchange between what exactly does that mean, the patient population, and how do I fit that in for certainly my cardiac patients. And over time, I've thought of this as a framework of how I decide what my pathway looks like, how I determine what type of remote care, and what does that mean, both from technology, the staff, what's needed, the frequency of monitoring, and also a framework of how I think kind of the future is going. So essentially the Acuity Pyramid, what I kind of term, is where I see remote care going, of which what are we focused on at the moment, largely in the NHS, is this top of the pyramid. And hospital at home right at the top, delivering acute level care, often requiring more in-person reviews. The middle layer being your virtual wards, essentially requiring hospital level observations. And that can be split between your step up or step down virtual wards. And again, what I've seen across is this interchanging between these two terminologies, but not really quite understanding what type of patient, what can they fit into to both, and where are the real system-wide savings. And the last component, be your long-term remote monitoring, where I really feel is that where the most savings and the preventative care, which will lead to the better outcomes within the health system. And that could be a long-term condition, and we're going to see some of how we use kind of remote care to deliver that into our presentations. But also I want to give an example of how we've done it on an elective care journey, how this proactive approach and remote monitoring can actually reduce the tap into these more medium acuity wards, your medium acuity virtual ward or your hospital at home. So just again, as a summary, your hospital at home, really avoiding hospitalisation, providing acute level care, often kind of IV medications, daily hands-on care. Your step down in acuity, your virtual wards, trying to either prevent admission or early facilitated discharge and prevent readmission into hospital. And really managing, the key thing is managing patients who still require hospital level observation, but safely can be done outside the hospital environment. And I'll give an example of one of the pathways that we're doing. And again, now the kind of the long-term remote monitoring, where it's really focused on proactive care and rethinking some of our outpatient journey. And what are some of the features of it? Again, in terms of target population, objective, really, if we focus on the hospital at home, it can really be delivered only in a short episodic care. You know, the cost benefit. I'm still yet to be convinced that there are system-wide cost benefits from any long-term or more within a 2-week span of patients staying at home where we're regularly going to see them. But your mid acuity virtual ward can certainly go into that phrase where we do have those bed releasing savings, and that low touch remote monitoring certainly in our experience has saved costs. And again, technology is really important in this. It is less, I see it less important in your hospital at home where you're having to physically see them regularly. But in your low touch virtual and certainly long-term remote monitoring, the ability to remotely monitor, but also have more asynchronous contact with them releases some of that efficiencies. And again, we will go through one pathway that really accentuates that. So we know that there's a lot of evidence for remote monitoring now, certainly in cardiac patients, where if we do that, we've got colleagues in Liverpool who've shown this in their heart failure population, that beyond your virtual ward 2-week stay, if you proactively remote monitor our heart failure patients for a period beyond their acute admission, you reduce their readmissions into hospital. So with that, what are we trying to do? Improve patient outcomes, the cost savings. And we know from a lot of our remote monitoring pathways that increased level of contact support, there's high degree of patient satisfaction. So what do you need to deliver that? I'm certainly going to say, given on this pathway, you need a digital offering, certainly for your virtual ward and your long-term remote monitoring, that allows you to seamlessly transition that patient across that acuity pyramid, and integrating that into other tools, PROMs, patient educations, self-management, that really kind of supplements your long-term proactive care, and then of course trying to integrate into your electronic medical record. Only with that will it be scalable across your patient population. I go back to my heart failure patient. I really hate the 2-week stay where you give that patient a kit and then you take it away from them after 2 weeks like their heart failure has gone away. That doesn't make any sense to me. So Ortus as a pathway, as a remote monitoring platform, tries to facilitate that. What it allows you to do is build your digital pathway dependent on your condition. Decide, is it a hospital at home? Is it a virtual or long-term? Decide the cadence of intervention. What data do you need? Does the patient need devices? Again, a lot of our remote monitoring is completely agnostic of devices. The utilization of asynchronous messaging and then supplementing that with your PROMs, PREMs, and health education. That really allows you to deliver an end-to-end complete digital pathway. Remote monitoring is far more than just getting some blood pressure and heart rates back to you. So I just want to be quick because of time. Again, the platform tries to supplement that with patient education on top and your scalable virtual ward dashboards. What I wanted to talk through some of our pathways that we have delivered across Barts and the London region. So our low-risk NSTEMI virtual ward was a novel virtual ward that we started now 2 years ago. NSTEMIs, as we know, is a significant patient cohort that comes into our acute take. The guidance is to try and deliver angiography within 72 to 96 hours of certainly higher risk patients. What tends to happen is our low risk patients get bundled on in, and so there are often long, certainly significant time spent in hospital while waiting for their procedures. And we are targeted to try and deliver at least 75% of our NSTEMIs within 72 hours of admission. And at Barts, given that we were certainly not meeting that, and that often led to low patient satisfaction and poor patient experience. So what we tried to do was take our low-risk patients based on a certain criteria, low GRACE score, troponin, LV function, and can we take them out into a 2-week virtual ward where we would remotely monitor them, but they would get a date for their angiogram. But so they wait at home, they get daily symptom reviews by an advanced nurse practitioner. If they were deemed deteriorating, they would be brought back into Barts Hospital to try and have their angiogram expedited. But the vast majority actually went on to just have their angiograms as per the date. This slide is a bit old now. We've now done over 1,200 patients, but the percentages are roughly exactly the same. Only about 11% of those, 2.5% of all our Atlas patients had to have their angiogram expedited. The vast majority were stable. I think less than 1% had readmission into an accident and emergency. Just to mention, so that reduced our length of stay for all of our patients, and we were able to increase our compliance with BSIS to 67% now. I think we're now over close to 70% of all our NSTEMIs being treated within 72 hours. And again, the vast proportion of those patients actually had disease. Nearly 50% of those patients went on to have either revascular or some form of revascularization. So In addition, low cancellation rates of these patients. We were changing non-elective patients to elective patients, giving a more predictable list. So not only bed day savings, but now Barts has made over £1.2 million in terms of elective recovery tariff by being able to change a non-elective patient into elective procedure. I'm just going to give one quick last example of a long-term remote monitoring and elective weight monitoring that we are doing pan-London. So that is all the cardiac surgical centres. So we knew post-COVID that there were excess in waiting times for cardiac surgery. We're seeing a shift between significant number of unplanned admissions, and therefore our non-elective to elective ratio was being increased. So what we did was we deployed across London that every single cardiac patient would be remotely monitored across all the centres for deterioration. And again, if they were deteriorating, they would move into our, either have their treatment brought forward or moved into our kind of low-risk NSTEMI equivalent for a bypass virtual ward, where we bring their their surgical procedure forward, but while remotely monitoring them till we do so. So I just wanted to give some of the, so the whole pathway was evaluated by UCL partners, showing significant cost savings compared to the standard of care and remote monitoring. But I wanted to go in depth with some of our Barts data. So between September and December, we remotely monitored over 1,400 patients. 120 actually were deemed to be escalating and had their treatment brought forward. We were able to show a difference between the unplanned admissions in the remote monitoring group versus those who didn't partake in the program, and we used those kind of non-engaged as our control. We saw a mortality difference between the two. So not only preventing unplanned admissions, we were able to show again a mortality benefit in remotely monitoring this kind of high risk group. That's whistle stop. Thank you very much. I'll kind of answer any questions at the end. You're on mute, Nick.